Well, thank you, Mike, and thank you, Anne, for kindly inviting me to come speak to you. It's 5 years since I last did, and some of the material I'll present today you've actually seen before, so apologies and yet no apologies for that, because it may be worth repeating. I can't work the computer myself, but I've got a very excellent assistant who's going to do that for me. Slide, please. You have to press the... Okay. Right. So, if this were a wedding, we'd be celebrating 25 years, which is a silver wedding, since the group was first founded. And since the charitable status was achieved, that's a China anniversary, 20 years. So I understand. Next slide, please. Just a brief recollection of the history of keratoconus. It was first described by John Nottingham in 1864. The term keratoconus wasn't used until 1869 by Johann Horner, and contact lenses have been used in the treatment, the management of keratoconus since that very same time by Eugène Cat. The first successful corneal transplant for keratoconus took place in 1936, and that was by Ramon Castro Viejo. Next slide, please. Castro Viejo's early transplants were actually square or rectangular. He had the idea that this would produce a simpler operation and produce less astigmatism. He was not right. And it's only fair to say that almost all corneal transplants for keratoconus since that time have been circular. There are 8 examples of Castro Viejo's square keratoplasties for keratoconus. Slide, please. The man in the trench coat is Castro Viejo. I think it's fair to say, others might disagree, that his work of 1936, the first successful transplant for keratoconus, began the modern era of the recognition and the place of surgery in the management of keratoconus. That era has been going on for 80 years, and it's salutary to remember that this group has existed for 25 of those 80 years, which is more than 30% of that time. So this group is taking its place in the history of keratoconus. Slide, please. What have we learned in the 25 years since the group effectively began? I would say these 3 things: the importance of interdisciplinary management, patient-organized self-help groups, and the careful evaluation and thorough assessment of any new medical or surgical claim. Next slide, please. Interdisciplinary management essentially means cooperation to the greatest possible extent between ophthalmologists and optometrists. The 2 professions are different, but they're complementary. And the patient is best served when the 2 professions collaborate and work together in the management of the condition. This applies very particularly in keratoconus. It's really important that neither profession should pretend to be the other. Slide, please. Possibly the founder or the pioneer self-help group was the National Keratoconus Foundation in America. That was 1986. And then this group, as we've been hearing, was formed in 1991, which was 5 years later. L'Association Keratoconus in France began in 1998, and it is not really primarily for patients, but there are patient forums on its website. And Keratoconus Australia began in 2000, run by volunteers, and has aims very similar to this group. So once again, you can see the place of this group in the existence of self-help organizations for keratoconus. Very important. Slide, please. No, you've done it. Thank you. New operations are sometimes introduced by surgical enthusiasts. I've used inverted commas around the word enthusiast because there are other less polite words I could have chosen. And they do this sometimes without critical evaluation of the results, both short-term and long-term, and without randomized controlled clinical trials that can compare a new technique with existing practice. Now, these enthusiasts often practice in the private sector where they find it easier to convince patients than their colleagues of the merits of their new techniques. It's really important, vital, to remember that in general, surgical procedures carried out on the cornea are irreversible. It doesn't matter what people say, they're irreversible. Slide, please. This hasn't shown up very well on the screen. I apologize for that. But I want to tell you about this, the theory of diffusion of innovations, which was introduced by an American sociology professor called Everett Rogers in 1962. It's the process by which an innovation is communicated over time among the participants of a social system. An innovation can be a new surgical procedure. The social system we're talking about is the medical community. And the yellow S-shaped curve shows how an innovation is accepted. There are innovators. They constitute only a very small proportion of this community, with 2.5%. Early adopters, 13.5%. Then there is the early majority. That's at the top of the blue curve, the bell-shaped curve, followed by the late majority, and finally 16% of laggards, people who want nothing to do with it until they're forced into it. And the yellow S-shaped curve shows how an innovation becomes accepted over time until it is the leading market force at the end of this process. This applies to any innovation of any kind. It was first described in rural terms, in terms of farmers in Iowa accepting modified corn seed. But it could apply equally to the take-up of new inventions that we've all seen in our lifetimes, things like Anne mentioned, the internet, the mobile telephone, even the television if you're a little older than that. Brexit, there's an innovation for you. I won't go on about that. So it's really interesting. This applies very strongly in surgical innovations. I'll mention it again later. Slide, please. The management of keratoconus, when the group started in 1991, was with spectacles or contact lenses. There was surgery of various kinds. It was mostly corneal transplantation. Full thickness transplantation had been started by Castro Viejo in 1936, and partial thickness or lamellar surgery had been practiced for even longer than that. We'll come on to specific operations in a moment. So that was the picture in 1991. Next slide, please. The picture today reiterates exactly the same on the left-hand side. Spectacles and contact lenses. The importance of those has, if anything, grown because of improved techniques and improved materials. To non-transplantation surgery, we can add collagen crosslinking in 1998, Intacs in 2000, and to corneal transplantation, on the right-hand side of the slide, we can add, from 2001, the use of the Femtosecond laser. I'd like to say a little bit about each of these. Next slide, please. But before I do that, I'd just like to answer this question: is surgery now an alternative to contact lenses with the increase in scope, sophistication, predictability of surgery? The short answer is no. The risks of surgery compared with the risks of contact lenses are greater in both the short term and the long term. And I'm repeating what I've already said, but I make no apology for it. Surgery is irreversible. The surgical options do improve as time goes by, as we have new technologies and better instruments. Next slide, please. As I said when I spoke to you last, 5 years ago, surgery is not like having a job done on the car. It involves at least two human beings, the surgeon and the patient, and both of them can behave unpredictably. The outcome can never be guaranteed, and the best that can be offered is a favorable benefit-risk balance. Slide, please. In 1991, yes, it was a corneal transplantation was an an inpatient procedure. There was no guarantee of surgery on a particular day, and I expect many of you remember that. This was due to donor material availability, transport problems in getting the donor to the recipient hospital, and elective surgery was always postponed elective surgery such as corneal transplantation was always postponed if there was emergency surgery to do. So there are a lot of reasons why the operation wouldn't take place on the appointed day. And this was very discouraging for the patients. The patients had a general anesthetic and they stayed in the hospital, as Anne has mentioned, usually for between 2 and 5 days after the operation. Next slide, please. Keeping the eye still for surgery is one of the prerequisites. You see, the eye is spherical in a spherical cavity and it rolls around. It's designed to roll freely around. But it must be completely still for transplant surgery. And so it is fixed in a single position by the use of sutures or stitches under the muscles that control it. That is the one above and the one below, the superior and inferior rectus muscles. Next slide, please. How we do that is we grasp the muscle tendon through the conjunctiva and put a needle under it, which we can then tie to the drapes around the patient's eye. Slide, please. How big a transplant to do? Well, the surgeon may already have decided at the time of seeing the patient in the clinic, but at the time of surgery, we can use a caliper to be sure that we can include the whole of the keratoconic area within the transplant, but at the same time keep it as small as possible, because small diameter transplants are less likely to undergo rejection. And the size we measure with the caliper is the size we call for, the size of trephine that we call for the operation to begin. Slide, please. Lots of different trephines have been described and developed over the years. When I started corneal surgery, I was given a choice of one, which was the top left. This is a perfectly good, sharp instrument, but it completely obscures the view of the surgeon. It's much too big. The one on the top right's a little better because it's got a cutout which you can look through. But once you put that top left hand trephine on the eye, it's an act of faith if you use it, because you can't see what you're doing. That is why the one on the bottom left, which is a short, hollow cylinder, is so much better. You can actually see through it, and you can see exactly what is happening as you rotate it between your finger and thumb. Bottom right is a vacuum trephine, which is used in lamellar transplant surgery. It's called a Hesburg-Baron trephine. Slide, please. Holding instruments. You may think you just hold an instrument and operate with it, but there is actually more to it than that. The picture on the left shows 3 different ways of holding the same instrument. At the top, the most stable way is when the instrument rests in the crook of the hand between the thumb and first finger. That gives it very good directional stability. Second picture down is resting against the first joint of the first finger, and that too gives good stability. At the bottom, there is no stability to be obtained from the finger the instrument is literally being held between finger and thumb. Now, the interesting thing about the design of these instruments, if you look at the middle picture, is that when closed, when it's functioning, when it's holding a needle, this is a needle holder, when it's closed, its cross-section is circular. So it can be rotated between finger and thumb, and that's the only movement that's necessary to force the needle through the tissue. That means there's no extraneous need, there's no need to move the hand, you simply rotate the instrument. It's designed specifically for that purpose. And as such, beautiful and satisfying to use. The one that I preferred is the one on the right. It is shorter, it's definitely a fingertip instrument, and other people said, why are you using that awful thing? But I found that the best in my particular hands, or I should say, fingers. Slide, please. You may wonder why we don't cut the cornea with scissors. Scissors are very good at cutting things, aren't they? But they're actually a shearing instrument. The blades produce a shearing force. And if you were to cut a cornea with a pair of scissors, you would end up with a dreadful profile, as you can just see at the right-hand side there. It would not be a square cut. So we start the incision with the trephine. We continue it with a sharp scalpel blade until it's almost complete. And we finish it off with micro scissors, which are suitable for this purpose. Slide, please. Reusable scalpels become blunt very quickly. It's better to use a disposable blade. And in 1991, we made our own from razor blade, from Gillette blue blades. Perhaps some of you might remember them. You can't get them anymore, at least not easily. They were very sharp. Slide, please. We'd put a blade into an instrument like this, close it and lock it, and then rotate, holding the blade in a swab, rotate quickly, and that would produce a shard of metal, sharp metal, which was the disposable scalpel. Very satisfactory. When stainless blades appeared, it didn't work because they didn't break cleanly. So we had to think of something else. Next slide, please. Wealthy surgeons in 1991, or fortunate surgical units, had diamond knives. These are the sharpest blades known, and they produce the smoothest cut. And so this is now the instrument of choice, the diamond blade. Slide, please. When the incision is almost complete, we can start to use scissors. These are micro scissors, very fine, actually finer than the ones in the picture, but they're also right-handed and left-handed. You see, the surgeon is sitting in one place. He doesn't move around the eye. He stays in one place. And so for going left, it's more convenient to use left-handed scissors, and for going right, right-handed scissors. And this produces the best profile. You're aiming for a perfect rectangular profile in the cut. Next slide, please. Lots of different forceps available for holding the tissues. The one at the top is called a toothed forceps. You can see why. It's got two teeth going into one. And that inevitably produces a certain amount of tissue damage when you hold the edge of the transplant with it. On the left, and it's, I'm afraid, invisible even to me, and I'm right on it, is a forceps that has tiny little, not teeth, but little circular curled pieces at the edge that just hold the tissue very precisely in one place, and they do much less, in my view, much less tissue damage than tooth forceps, and they were the ones that I preferred to use. On the right there are plain forceps. These have no teeth at all, they're perfectly plain, and these are the ones we use for handling the suture and tying the knots. Next slide, please. We use, in 1991, and I think still now, we use a very fine monofilament nylon suture, which has the blade fixed onto it. You don't have to thread the needle. The material is 0.02 millimeters in diameter. It's very strong, and it's completely inert, which in turn means that it's non-absorbable and must eventually be removed. Slide, please. The suturing technique is to try to make both sides, the top and the bottom, of the transplant and recipient meet. So it's necessary to put the needle in very deeply, not quite full thickness, rotate it into the tissue and out again through the recipient, again at 90 degrees, so that you end up with a profile which unites the front and the back of the transplant. This makes for a much more secure wound and much less astigmatism. Note that we don't go right through the cornea, but just almost full depth. Next slide, please. Once we've tied the knot, we bury it. This results in less post-operative inflammation, and it's also much more comfortable for the patient. Those little knots, even of 10-0 nylon, are really quite unpleasant if they're on the surface. So we hold the suture, the tied suture, and we rotate it into the wound. You might think that would make its removal difficult when that has to be done, but it doesn't. It's actually very straightforward. Next slide, please. There are various different suture patterns that different surgeons use in different situations. Once again, I'm afraid the definition on the screen is not great, but I think in top left you can see that there is an in and out pattern, a zigzag pattern. That's one suture going around the whole cornea, tied in one place. The knot is somewhere near the top. That's known as a continuous suture. The one on the right, top right, is a double continuous suture, a beautiful piece of work surgically. That's something to be gazed at in admiration, a beautiful piece of work where you have two continuous sutures which are supporting each other and which can be removed separately if necessary. Bottom left, we have a combination of interrupted sutures, single sutures, and a continuous suture. And bottom right, we have the suturing technique that I preferred to use, that is a number of individual single sutures, so-called interrupted sutures. It's usually 16. And the important thing here is that they should all be absolutely radial, so that they're pulling in the right direction, pulling the wound together in a radial fashion all the way around the eye, and the tension in all of those sutures should be as equal as possible. Once again, we're talking about eliminating as far as possible astigmatism. The great advantage of interrupted sutures is that they can be removed individually as necessary in the control of astigmatism. They don't all have to be taken out at once, as continuous sutures do. Slide, please. Let's talk about intacs. It's actually the wrong word to use. The correct word is intracorneal ring segments. Intacs is just a make. It's like referring to all vacuum cleaners as hoovers. That's wrong. So intacs is what they have been called. Next slide, please. And the principle, as you know, is that if you push in the sides of a curved tent, the dome at the top becomes slightly flattened. Slide, please. And this is the artist's impression of one of those perspex sectors actually within the cornea. Next slide, please. And here is an operation in which you see the finished result, the two sectors of this PMMA material within the stroma of the cornea, supposedly forcing it out and flattening the dome at the top. Slide, please. The NICE, the National Institute for Clinical Excellence, as it was in those days, gave guidance in 2007 saying that the current evidence on safety and efficacy of corneal implants for keratoconus appears adequate to support the use of this procedure, provided that normal arrangements are in place for consent, audit, and clinical governance. And you can still download that very easily. Next slide, please. But NICE also commented, none of the studies, that's the studies they considered before issuing this guidance, was a randomized controlled trial. It is well known from other ophthalmological procedures assessed against sham or placebo interventions that visual acuity outcomes can be subject to considerable placebo effects. Variation in the severity of keratoconus between studies makes comparison difficult. And finally, although one of the intended benefits of corneal implants is that they may allow patients to wear contact lenses, only one study reported directly on this outcome. So a distinct lack of scientific evidence in support of this technique. Slide, please. Collagen cross-linking was introduced in 1998. Next slide, please. I'd just like to point out that collagen is not unique to the eye. It's widely distributed throughout the body. Our bodies are held together by collagen. The joint capsules, the ligaments, tendons, so are collagen. And do I really have to start again? Anyway, what I was going on to say was that collagen is found in all sorts, in just about every part of the body, and the phenomenon of cross-linking, which can be age-related, is known in tissues other than the cornea. And the first of those examples, thank you very much, almost there. The first of those examples, carry on please, carry on one more, was collagen cross-linking in human bone and cartilage, which was found to be age-related. Next slide, please. And also in the heart. This is an experiment in rats, but I just wanted to illustrate the fact that collagen cross-linking is something which has been known for a long time and is not unique to the cornea. Next slide, please. Cross-linking occurs naturally with age. Any eye surgeon who's ever operated on an infant knows how floppy the infant cornea is, and conversely, in old people, how very stiff it is. And that is because cross-linking continues throughout life. It's enhanced in diabetes, and it is thought that it is it is believed that it is reduced in keratoconus. Next slide, please. How could we increase cross-linking in the cornea? Well, what about glutaraldehyde? It's easily available, it's cheap. It's a laboratory fixative, hard surface disinfectant, but it's toxic to living tissues, and you can't control the depth of penetration. So that was a silly idea. Just cross that out with the next slide, please. Crossed out. Now let's move on. Something more sensible. Next slide. Singlet oxygen and superoxide radicals are released by the riboflavin molecule when it fluoresces. And riboflavin you may know better as vitamin B2. Fluorescence can be stimulated by UVA light at 370 nanometers, hence the combined use of riboflavin and ultraviolet light in collagen cross-linking. Next slide, please. It was first investigated by Theo Seiler and his group in Dresden. And they showed in animal studies that the combination of 0.1% riboflavin and 30 minutes of UVA at that same wavelength penetrated 300 micrometers into the cornea. So we were getting somewhere. But all the cells in the treated zone were killed, all of them. And the ones beneath were not. Next slide, please. So if we just remind ourselves of the structure of the cornea, the epithelium at the top resting on Bowman's layer, the vast bulk of the cornea being made up of stroma, which is full of cells. You see those streaky things on the left there. And the dot things on the right, they're cells, they're living cells, they're called keratocytes. Now, the epithelium and the cells of the stroma must be killed by collagen crosslinking, by this toxic process. But what we're trying to preserve is the bottom layer, shown in pink on the left, and you can see the individual cell nuclei on the right. This is the endothelium, and that must not be damaged at all costs. As you know, it doesn't repair itself. Next slide, please. The first clinical studies were published in Dresden in 2003 and in Italy in 2006, and they showed that the process of collagen crosslinking halted the progression of keratoconus. The largest study to date was published in 2008. This was in 241 eyes with a follow-up of 6 years. And there was another study reported in 2009 in 28 patients. This sounds good, but we have to recall that none of these studies was a randomized controlled clinical trial. None of them. Next slide, please. The first randomized controlled clinical trial was designed by an Australian group, which published its 3-year data in 2014. There were 100 eyes with progressive keratoconus randomized into either cross-linking or control groups. And they published the results, the 3-year results, for 46 treated and 48 untreated eyes. Treated eyes showed a sustained improvement in, you may know this term, Kmax, which is the maximum simulated keratoconic value, UCVA, which is uncorrected visual acuity, and BSCVA, which is best spectacle corrected visual acuity. Sustained improvement in all those 3 dimensions. I mean, this is a very, very brief summary of the results of this study, which continues. Untreated eyes showed further progression. Next slide, please. So you can see that the purpose of collagen cross-linking treatment is to prevent the further progression of keratoconus in early cases. And Moorfields has now begun the Keralink study, which is multi-center involving Moorfields, Liverpool and Sheffield. And this is an observer-masked, randomized controlled trial. The important thing about this study, well, many important things about it, but it is in young people, aged between 10 and 16, who have been shown to have, by criteria that are carefully defined, progressive keratoconus. They're going to be followed up for 18 months in the first instance after entering the study. So this is something that we watch with enormous interest. And there are also American FDA phase 3 trials in progress. Next slide, please. The problem areas in collagen cross-linking: there may be a persistence of corneal haze for months. It may be difficult to measure intraocular pressure accurately. And we mustn't forget that we can demonstrate that those keratocytes and nerve fibers are killed. And the stroma takes between 3 and 6 months to repopulate itself with living cells. There is, as I've said, a danger to the corneal endothelium if the treatment isn't properly controlled. In other words, if it goes too deep. Slide, please. If the corneal stem cells, which produce the epithelium, are not properly masked, they too can be damaged, and that could be a serious matter. And the minimum stromal thickness that can be safely treated is about 400 micrometers. The very rare but potentially devastating complication, very rare, is corneal infection. Next slide, please. I'd just like to mention DALC, because that was available in 1991, which is why it's on the old slide, but it's worth talking about because a lot has happened in recent times. Next slide, please. So this is deep anterior lamellar keratoplasty, previously called lamellar keratoplasty or lamellar corneal transplantation. And years ago, this was a normal preparation of an eye for a full-thickness transplant. New technology is now used, automated instruments, keratome for preparing the donor disc, and what you may have heard of as the big bubble technique. Next slide, please. So only the front part of the cornea is replaced, that is the epithelium and the stroma. The back part is not replaced, so you leave Descemet's membrane and the endothelium, which are usually normal in keratoconus. Endothelial rejection, which is the most serious form of corneal transplant rejection, should be avoided in this procedure. Next slide, please. And there isn't really time for me to go into how this is done, but what these slides show is how a vacuum trephine is used to do a partial thickness dissection of the cornea, which is then peeled away, and the transplant is sewn in place on top of that very, very thin remaining layer. Next slide, please. Let's move on. Next slide. Next slide, please. Next slide, please. Thank you. The NHS Ocular Tissue Advisory Group in 2010 showed 5-year transplant survival estimates for keratoconus in both penetrating keratoplasty and DALC. And there was no difference between the two groups in their experience in 2010, 5-year transplant survival. Next slide, please. Since that time, we've had better data, bigger data, from the Australian corneal graft registry, which most recently reported in 2015. They have 28,000 transplants registered, 22,000, nearly 23,000, were traditional full-thickness transplants. 1,285 were traditional lamellar transplants, and 1,040 were DALCs. Next slide, please. Now, this is an interesting slide. This shows the Australian experience of the changing patterns of corneal transplantation from 2000 to 2013. The bars in orange, which are increasing towards the right, represent posterior corneal transplantation, which is used when the endothelium is diseased. And that's a treatment which is now, to a very large extent, replacing penetrating keratoplasty for the management of Fuchs dystrophy and endothelial failure. So that has resulted in a very large difference in the balance between the different surgical options. If you look at the sort of lime green bars, which are there almost from the beginning, that represents DALC, and you can see that it isn't such a massive increase, but they have increased enormously in recent years. So this shows that the surgeon, from having had very simple options, almost only one option in 2000, now has many in 2013. Next slide, please. What about survival? Well, this is the survival from the Australian study of 2015. The blue line, which is quite smooth, and it's going from 0 to about 27 years, is penetrating keratoplasty, the regular, normal keratoplasty. The rather jerky, what shall I call it, mauve line, it's difficult to assess. It's small numbers which produce the jerkiness of the outline of this line, seems to meet the penetrating at about 13 or 14 years. Now that represents DALC, and you can see that although it's difficult to compare those two lines in terms of the quality of information that's being presented, it's not very far off penetrating keratoplasty. But anybody who thought that DALC was going to be a massive improvement on penetrating keratoplasty, which it ought to be, bearing in mind the theory we're talking about, has been shown to be mistaken by these studies. Next slide, please. And this is a bit of a, you can't interpret this one quickly, but you can notice that the best results are the top curve, which is in blue, and so this is in keratoconus patients. Keratoconus patients still get the best results from corneal transplantation. Next slide, please. Why doesn't DALC replace PK? Well, it's a fairly new technique requiring different instruments and specialist surgical training. It's technically demanding to carry out. There's a high incidence of unintended perforations. It's particularly difficult in keratoconus, where the cornea is very thin and fragile, and if it's scarred, the dissection of the layers of the cornea may be difficult or even impossible. And if there's been a hydrops, the cornea may be even more fragile than usual. And the final conclusion there is it hasn't so far shown better results than PK. Next slide, please. Femtosecond laser. This is the last bit. I apologize to Steve Tuff for running over my time. The femtosecond laser was introduced in 2001. I don't know whether you're familiar with this technology. Next slide, please. What is a femtosecond? It's 10 to the minus 15 of a second, which is a millionth of a billionth of a second. So quite short. This ultra-fast infrared laser works at 1053 nanometers, and it works by producing a rapidly expanding cloud of free electrons and ionizing molecules which disrupts transparent tissue. And the extremely short pulse duration limits collateral damage of other tissues. This produces more precise surgery than can ever be achieved by hand. And if you wish to produce a perfect stepped incision for extra strength, then you can do it with the femtosecond laser. Next slide, please. I have to... Courtesy of my colleague Madhavan Rajan at Addenbrooke's Hospital in Cambridge, here is a femtosecond laser cataract operation. If you look at the picture on the right, you can see that the anterior capsule of the lens is being disrupted. It's producing a fair amount of debris, which is hitting the back of the cornea. That bothers me a bit. And then the disruption is carried deeper into the substance of the lens, making it easier to remove by suction at the end. So that's a cataract operation carried out with the aid of the femtosecond laser. And just very briefly, another short bit of footage from Addenbrooke's. This is a corneal dissection. You can see on the right, you can see a white line appearing in the cross-section of the cornea. This is delineating a lamellar transplant. So it's all over rather quickly. And then an air bubble separates the two parts of the cornea. So if we could now move on to the final slide. The disadvantages of the femtosecond laser, actually it isn't the final slide, it's the next to the final slide. Back, please. The disadvantages, it's very expensive to purchase and to maintain. It takes longer than a phaco operation, that's the standard cataract operation, which means that fewer cases can be performed on the operating list. And data on outcomes and complications is so far scarce. It has stimulated skepticism in some quarters, and I found this quote, which I thought you might enjoy, from Dr. Stephen G. Safran of New Jersey. His assessment of the femtosecond laser is as follows. The assistance the femtosecond laser gives cataract surgeons is as unnecessary as bathroom attendants in high-dollar nightclubs and restaurants. Thanks, but I can grab the towel and soap myself. So I think it's fair to say the jury is out. Next slide. Final slide, please. But that takes us right back to Everett Rogers and his diffusion of innovations theory. The femtosecond laser has reached the innovators. It has interested early adopters, where money exists to purchase this enormously expensive instrument, but it's nowhere near the start of the bell-shaped curve. And we'd all like to think that eventually it would reach 100% saturation and its use would be standard in corneal surgery and in cataract surgery. But I think we're a few years off. So thank you very much.